Hello and welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. Our Executive Director, Stephen Paler, cannot be with us today due to canceled airline flights. Thank you for your interest in the Foundation's Dr. John G. Bartlett Memorial Education Series. We're pleased to offer today's program entitled Importance of HIV Testing in Different Population Groups on National HIV Testing Day. To access this and other webinars and educational programs, please visit our website at www.idsafoundation.org. Sign up for our monthly newsletter and stay informed about the mission-critical work of the IDSA Foundation to reduce the burdens of infectious diseases worldwide. I'm honored to introduce today's moderator, Dr. Rupa Patel, who will in turn introduce the rest of the faculty and patient advocates. Dr. Patel is an infectious diseases physician and is a research associate professor in the Division of Infectious Diseases at Washington University in St. Louis. She is the former director of the Midwest CDC HIV Prevention Capacity Building Center. She has experience in developing non-traditional PrEP delivery models, which includes pharmacy-based care, teleprep, and incorporating at-home self-lab testing. Dr. Patel?
Thank you so much, Diane. Thank you for the audience for being here today and your attention. It is my great pleasure to introduce the panelists today. Before we start, some housekeeping. Please go ahead and remember to put your Q&A in the chat, and there's a Q&A section, as well as there will be surveys after this, so we really appreciate if you could fill them out. In terms of our speakers, today is Carl Baloney Jr. He is the Vice President and Chief Advocacy Officer of AIDS United and is a longtime advocate for vulnerable populations and has focused much of his career on innovative policy solutions that benefit disenfranchised communities across the country, with a particular focus on the rural South. Carl enjoys deep relations with policymakers and an in-depth understanding of the legislative process, which is depicted through his current work as he leads AIDS United's federal HIV advocacy with its more than 50 member organizations along 35 key issue areas ranging from access to care, harm reduction, sex worker rights, racial justice, and housing. Next, it's my great pleasure to introduce Murray Penner, who is the U.S. Executive Director for the Prevention Access Campaign, PAC, and the U equals U campaign, undetectable equals untransmittable, and previously served as the Executive Director at NASTED. Murray has strong expertise and experience in HIV and hepatitis treatments, as well as HIV White Program, drug pricing, and serves on the boards of AIDS Treatment Activist Coalition, ATAC, and Harbor Path, Inc. He has a deep personal interest in ensuring that people living with HIV have access to the care and support they need to become undetectable, helping people achieve sexual health and quality of life, and reducing HIV stigma and shame. Next, we have Bridgette Picou, who's a licensed vocational nurse in Cathedral City, California. She often works with the WELL Project and with a focus of HIV in women, and is also the president-elect of the Greater Palm Springs chapter of the Association for Nurses and HIV/AIDS Care. Next, we have Michael Reed. Michael Reed is a longtime PrEP user and advocate who resides in Missouri and Illinois, and he has firsthand experience with insurance-related challenges in accessing care, with a particular focus and deep insight with getting care and Medicaid non-expansion sites. Next, we have Brian Taylor Orr, who's a health educator with a passion in reducing systemic barriers to people living with HIV. He himself is diagnosed at the age of 20, and Brian has shaped his career to be in positions to create health equity within health systems that benefit the many lives impacted by the epidemic. He is a current MPH student at the University of North Texas Health Center in Fort Worth, Texas, and Brian plans on utilizing his strengths and life impact and experiences to provide culturally relevant healthcare navigation for those affected with HIV and to improve the quality of life. Next, we have Jesus Villalobos, who is also a longtime PrEP user and advocate who resides in St. Louis, Missouri. He has had experiences dealing with insurance-related care issues, care from different providers, scheduling routine testing, as well as taking different types of PrEP. And lastly, we have Deirdre Johnson, who is an HIV care advocate from Virginia. She's the co-founder of Ending Criminalization of HIV and Over-Incarceration in Virginia through the ECHO VA project, which is a coalition. She's the state leader for the Positive Women's Network. And today's content, we're going to start with giving you just the overview of HIV testing and the different types, linking HIV testing to the status neutral care continuum, and integrating with an emphasis of the CDC guidelines and changes for PrEP. And then we'll segue into our speakers where they'll comment on PrEP awareness and the different aspects of the care continuum, both on HIV prevention and the care side, highlighting solutions and barriers to retention, as well as stigma, and highlighting the positive impact that U=U has had on this campaign. And so next, this is also going to be peppered, and I'm excited to offer the rich discussions we're going to have from our actual advocates who have gone through the PrEP care cascade and HIV care continuum. So without further ado, I'm going to bring our first conversation with Michael. So Michael, please tell us some of your experiences with HIV testing and care, and what advice you would have for providers based on your experiences.
Thank you, Dr. Patel. It's been a journey when it comes to HIV awareness and the whole PrEP, situation. I think it's been a game changer. I think my advice would be when it comes to, the doctors that prescribe it, just to be a little bit more proactive when contacting your patients. I know it's every 3 months you do the follow-up, but a simple phone call or text say, hey, how are you doing? How's the medication working? It would definitely be beneficial. And like I said, it's been a journey when it comes to the PrEP. Like I said, I feel like I did my part on HIV awareness, trying to protect myself and informing others, and yeah, it's a good thing.
Excellent, thank you, Michael. And lastly, for your peers in the audience, and for providers and advocates as they speak to community members, what advice do you have about testing and going through that PrEP care journey? What would you tell them?
It is a journey, and with the journey, you learn so much, and it's a good feeling to know that you've done your part in learning about HIV awareness, ways to prevent HIV, certain medications out there. It's a good feeling. It is a journey. It can be a little nerve-wracking, but you have a lot of doctors, such as yourself, Dr. Patel, that are willing to help and guide you along that journey. So, don't be afraid to do your part, because it's a good feeling.
Thank you, Michael, for your thoughts. And now we'll transition just to a brief overview on testing and PrEP before we get to hear experiences from Brian. And so I just wanted to segue into how the speakers today and the advocates will be laying out their talks. I wanted to start, and introduce, if the audience already doesn't know about this, our status neutral continuum of care. And so it means in the beginning, we get HIV testing, but now there are efforts to go ahead, and after that HIV test result is communicated to the client in front of us, we are starting to discuss about awareness and the aspects of treatment. If you go to the right of the slide, and to the left, the prevention care toolbox, which includes PEP and PrEP, or pre-exposure prophylaxis and post-exposure prophylaxis. Both steps, then after awareness of what is next, requires linkage to care, which means getting into a doctor's office or a provider's office or a non-traditional care site to talk about the next set of treatment and receiving a prescription. And then after the prescription, going to the pharmacy or having that pharmacy on site and getting comprehensive care such as mental health and substance use, etc. And then going ahead and going through maintaining oneself on, in care, and also having the term adherence or taking that medication. And I want to highlight to the group, after HIV testing, there is a lot of work to help clients go ahead and get into the right-hand side of the slide. Treatment as prevention is what is called as a public health entity. so we can move towards U equals U and limit transmission. And I also want to highlight the difference between adherence and retention. It's so important to retain people in care, whether it's PrEP or HIV treatment, and talk about what are ways to support that individual that act on the social determinants of health. And then in turn, helping someone take their medication, which I said is different than retention. I just want to have an overview, since today is HIV testing day. There are 3 types of HIV tests today. I encourage everyone to go visit the CDC website in order to get resources. And with that being said, are 2 terms that everyone should know in the room. While I said that we have 3 different types of tests, we have a nucleic test that can look at the actual HIV RNA, and then we have a protein combination test with an antibody, and then we have antibody tests. And what's important is to talk about the eclipse period. To the right of my slide, this is a definition taken off from the CDC website, which we all too often don't look, and that is, in general, following an exposure that leads to HIV infection, the amount of time during which no existing diagnostic test is capable of detecting HIV is called the eclipse period. To reiterate, it is the time we don't have an accurate diagnostic test to tell us that we may be HIV positive. And then we go into actual testing. And so you can see an RNA test can test you and may detect HIV infection earlier in terms of the days after an infection disseminates. And the bottom of this slide of this graph shows you the days after infection and the detection per test. And then you've got the P24 antigen protein, that is your combination test or 4th generation test that we talked today. It's point of care with a finger prick and also by drawing your blood in a serum test. And then you have your antibody test. And what's also important is to talk about the other definition, which is called a window period. And I want to highlight there's a window period for each test. And that definition is the time between potential HIV exposure and an accurate HIV test result is referred as the window period. And I just want everybody, advocates in the room, to be able to know these definitions and to convey that to their clients, whether they're a provider or they're an HIV tester, through an ASO or community-based organization. I just want to transition us, because everyone will get the slides in the audience, to 2 graphs from a recent article in the Lancet HIV in 2021 by Ambrosiani and colleagues. And they laid out very nicely another way of looking at our traditional stages of primary HIV infection, from the eclipse period to the days following an HIV infection, and also how the tests have their window periods. But they also laid out something new in the era of PrEP use that we're dealing with, and that is, what does the HIV primary infection stages look like during the use of HIV? And they laid out 3 scenarios, which you see on this slide. I know it's a busy slide. Like I said, you can go to the actual article. You can ask IDSA Foundation to get you a copy of the article, and you can also have these slides for reference. And the first scenario is really when we have, when PrEP is initiated in the setting of the window period, that undiagnosed HIV infection and during the test window period. And that is where you can get HIV, someone takes PrEP, and you can get resistance because someone is taking pre-exposure prophylaxis. And then you have 2 other scenarios, with scenario 3 and 4, where you don't have any PrEP use and you get the HIV infection and there's really no drug resistance. And then very, very, very rarely you can have a breakthrough infection with HIV. And that is when you have a resistant, PrEP-resistant strain, essentially overcome the PrEP and you can get HIV. And lastly, there are really rare scenarios popping up where people can be adherent to PrEP with cabotegravir and tenofovir-based PrEP and have a breakthrough infection. And so I want to lay out Bridgette's talk, who will be next after we talk to Brian, about just what is PrEP. PrEP is a concept. It's a medication that's used prior to someone is exposed to HIV. It essentially blocks HIV from entering the body. I want to highlight PrEP is in the context of the prevention toolbox, which is routine HIV testing, couples testing, blood supply screening, using PEP and PrEP, STI treatment, male circumcision, education about behavior modification, abstinence, condom use, the entire works that we have in prevention. We have long-acting biomedical HIV prevention on the horizon on this slide by the NIH. We've got rings and implants and injectables and antibodies being tested. And this falls into our goal of ending the HIV epidemic. Pillar 3, where after we diagnose and we treatment as prevention. The third pillar is preventing people from acquiring HIV who are at risk by using PrEP. And I'll segue into the CDC guidelines from December 2021, where we've got new parameters for testing, whether you're on PrEP before or not on PrEP. Again, you'll get these slides. I'm just highlighting the new testing algorithms and where the HIV testing has changed. And there's these beautiful table A and 1A and 1B that providers and advocates can use when they talk about PrEP, and it lays out eligibility both by history and by clinical, and how to dose PrEP, and then how to have follow-up care. There's a table for both oral PrEP and cabotegravir-based PrEP. This is a brief introduction to the guidelines. And then we can also talk about same-day PrEP in this context with testing. Remember, time your tests when you prescribe PrEP, and that testing window is about 7 days of getting an HIV test before you're prescribed. And again, you'll get these slides, and this was a Lancet article about same-day PrEP. This is considered the standard of care, and that's why I wanted everyone in the room to think about the term same-day PrEP. And we have same-day ART treatment or rapid start ART or ARV treatment. And don't think you're alone. There's tons of resources by the CDC and HRSA and IDSA in terms of how to bill for HIV testing, PEP and PrEP, hotlines for doctors, providers, advocates, nurse practitioners, nurses, and registered nurses and provider physician assistants, as well as community-based organization managers, clinic managers, on how to run a clinic, make workflows, and also patient cases or client cases. And without further ado, I'm going to go ahead and transition to Brian. So, Brian, if I can hear from you, you know, as a person living with HIV, we're really eager to hear your thoughts about your testing experience, how you got into care, and, you know, kind of the advocacy around that has led you to your career today.
Well, thank you, Dr. Patel, for that amazing presentation. I truly appreciate you having me here today. So honestly, this is such a full circle moment for me personally, because on National HIV Testing Day, June 27th of 2014, that's when I found out that I was a person living with HIV. I didn't really suspect the outcome of that test to be positive. I thought I was doing everything in my regards to keep myself relatively healthy. I was in a monogamous relationship. I was with somebody for a couple years actually. And, but around that year, I heard a lot on the radio, advertisements, things of that nature about National HIV Testing Day. So I thought I would do my part and advocate for myself just to, you know, be a part of that movement and say I was doing my part. Little did I know that that day was going to change the trajectory of my life for, you know, for years to come. But like I said, I did find out I was positive about 8 years ago in 2014. And it shocked me because I wasn't expecting it. And but unlike so many other people that get that positive diagnosis, I had a lot of support around me. I had, you know, friends, I had family that came to my aid that day and really provided me with that, you know, unconditional love and support that a lot of people do not have. So I definitely want to thank them on this call while I have everyone here. Also, I had access to, you know, health insurance and counseling that really helped me through and aided me through that process of grief, and really reestablishing who I was as a person. Because I feel like a lot of times when people are diagnosed with HIV, they they have a sense of value that seems to diminish. And without my support and without the access to care and services and counseling that I had, I don't think I would have been able to pull myself out of that. So going into care, I really had to go through a mental process of really finding a lot in terms of just knowing that this is a forever thing. It's going to take time to kind of gradually get into it. But like I said, I had medical care that got me into care kind of rapidly. I had medication in my hand within the week of my diagnosis, and I just started taking medication as prescribed every single day. My physician was really, really good. He really did talk to me about what untestable was in terms of my health, but it really wasn't until a couple years, I would say 3 or 4 years after I was diagnosed, that I actually found out what U equals U meant for my, interpersonal relationships with others. So whether it be relationships with, partners or, dating or whatever the case may be, I found out that U equals U gave me a sense of, I could still do the things that I wanted to do before I found out I was positive. So I can date, I could potentially get married. If I wanted to have kids, Lord have mercy, I could do that if I wanted to. And it really helped me find a sense of worth within myself to be able to do exactly what I wanted to do before I was diagnosed. And also it kind of directed me into a new path in life, because before I found out I was diagnosed, I really didn't know what I wanted to do with my life. I was in community college, kind of wasting my parents' money, sorry, but wasting my parents' money just taking these basic courses. But then I kind of found the road of advocacy, and I found the road of public health that really re-energized my viewpoints on what I want to do in life. So I found, the school that I wanted to go to. I transferred over, got my degree in health studies, which is a community health background. And landed a job at Tarrant County Public Health, locally, my local health department. And now I advocate for so many people that don't have advocates that are behind him, who are newly diagnosed, who are, could be impacted by HIV, who are negative. But I get to advocate for so many people that don't have a voice now. And it's just a true full circle moment for me. So getting into care and reestablishing not only my physical health, but also my mental health to be able to advocate for others. And now being on this panel with everyone is just a full circle moment for me personally. So, yeah.
Thank you so much, Brian, for your insight and sharing the stories. And I know they're personal, so we appreciate your comfortability on this call. And now we're going to go ahead and segue to Bridgette Picou, who will take it away for PrEP eligibility and challenges in adherence and retention and how to overcome them.
Thank you, Dr. Patel. I appreciate that intro. Let me go ahead and share my screen so I can get to my slides for everyone. All right, so PrEP adherence and retention and care. And I apologize if I'm going to talk a little fast, but I want to make sure that I get through the slides and save space for our other speakers here. So is PrEP right for you? So PrEP may be right for you if you are HIV negative in any of the following scenarios, being that you are HIV negative and you have sex with HIV partners of unknown status or viral load and they don't participate in care. If you're not consistently using condoms, if you have multiple partners and you don't know their HIV status, and if you are HIV negative and you exchange sex for money, housing, food, or other necessities. And please understand that these are not about perceived risk or behaviors or preferences. It's simply a matter of why PrEP might be right for you or the reasons you may want to consider it. So how do you start PrEP? PrEP is provided by a licensed provider. And whether you use the oral or injectable, you'll start with some simple lab work to ensure that you're healthy enough for PrEP. And if you don't have insurance or adequate enough insurance to cover it, there are manufacturers programs, and also there's some government programs that can help you pay for the medication. So I'm on PrEP. What's next? Stay adherent, stay adherent, stay adherent. PrEP doesn't work if you don't take it. So you want to keep your follow-up appointments. Current guidelines are for every 3 months with ongoing testing, lab work, STD testing, and refills of your medication. Keeping your follow-up appointments is also great for peace of mind and the efficacy of your medication. And since PrEP does not protect against other STDs, condoms are still recommended for partners whose sexual history you are unsure of. And you want to stay in contact with your provider if you have questions on any side effects, adherence concerns, or other questions. So on the other side of the care continuum is that you've tested and you've acquired HIV. So what do you do now? Well, obviously we want to get you linked into care as quickly as possible. There's support to help you navigate your new life process and get your questions answered. The sooner you get yourself into care, the better your mental and physical outcomes can be. As a woman living with HIV and thriving with HIV, I can tell you that that's the truth. So much of the medical process of testing HIV positive and your care appointments are going to be similar to that of being on PrEP. There are some small differences that you navigate along the way. Adherence to your HIV medication is an imperative part of a healthy journey living with HIV. And please remember on a personal note that you are still you. You definitely did not become a 3 or 4 letter acronym at your diagnosis. So you are not HIV and it is not you. So why does adherence matter to your medications? Adherence is important to your quality of life. HIV is an inflammatory process that leads to all sorts of negative outcomes if it's left unchecked, and you have the ability to check those. There's a ton of medication options that you can discuss with your care provider. There's injectables, there's pill regimens. You and your provider can work out what works best for you. The medication is going to help you keep your viral load in check and your CD4 cells up, which again is important for your quality of life. And regular healthcare appointments and lab work and what I call persistent participation in care can help you catch any potential problems early and help extend your lifespan. And when you feel better, you have a better outlook on your life and how you choose to live it and how you choose to thrive with your HIV. And then lastly, a controlled viral load can lead you to be undetectable and untransmittable, U equals U, which Murray is going to talk about in a little bit. So retention and care. Why do we want you to get into care? Well, we want you to get in care and stay in care, which I recognize sometimes is easier said than done. Barriers to care can include things like insurance or lack of adequate insurance, transportation, your mental health, comorbidities, and sometimes your interpersonal relationships that you have. There are resources available to you. Use them, use them. If you feel like you've exhausted one resource, ask questions until you can find another. This is where your peer advocates or your PrEP navigators, your AIDS service organization, your ASOs, or your CBOs, which are your community-based organizations, can help. There are also reputable online resources that you can turn to. And then I am an advocate for advocating for yourself. The more you know, the better your outcomes will be. So enlist the help of other HIV positive people or other PrEP users if you're taking PrEP. The most important thing is to remember that your health matters more than any other barrier in your way, and you just have to keep chipping away at them until you can get yourself where you need to be, which is healthy and thriving. And on that note, I'm going to stop sharing my screen and I'm going to pass it over back to Dr. Patel. Thank you so much.
Thank you so much for all those wonderful insights, especially the personal story about you and the diagnosis and how not to be labeled. I want to go ahead and transition it over to, on that note, to Murray Penner, who has led our campaign on U equals U. Thank you so much, Murray.
Thank you, everyone. It is great to be here. I'm honored to be with these amazing panelists, and thanks for that introduction. I'm going to talk today just a little bit, and I'm going to talk very quickly as well about why U equals U is an important part of HIV testing. It's just a critical, important message that people living with HIV and those who are testing for HIV need to know about. So as a person living with HIV in 1996, I remember when we learned that effective treatment will keep us alive. It was a huge milestone when we learned about that. Treatments have advanced, fortunately, and we are now at a place where we know that treatment allows us to live a long and healthy life. And as a bonus, we won't transmit HIV to our sexual partners. So undetectable equals untransmittable, or U equals U. People living with HIV who are on treatment and have an undetectable viral load cannot or will not or won't transmit HIV through sex. Brian mentioned it, Bridgette mentioned it. It's very important that people living with HIV and those who are testing for HIV as well as the general public, know about this important fact. It's based on 4 major studies with over 125,000 sex acts between HIV positive and HIV negative partners, and there were 0 transmissions. And so it's a scientific fact that U equals U. So why is U equals U such a game changer? Well, it improves the quality of our lives, as we've already talked about, and it has the potential to reduce stigma and eliminate fear and discrimination. It also really accelerates our progress towards ending the epidemic, especially across the continuum, including diagnosis. It does reduce anxiety associated with HIV testing. I'm going to talk about that a little bit more in a moment. And it's an incentive to start treatment and stay on treatment and be adherent. And as Bridgette said, adherence is important to treatment as well. U equals U also has the opportunity to help modernize discriminatory laws, policies, and practices. And it is a call for universal access so that everyone has access to the treatment, to the care, and the diagnostics they need to stay healthy. It's a win-win. It's a win for personal health, and it's a win for public health, and something that we should be sharing with everyone. So U equals U is very simple. It's based on obviously being on treatment. That is critical, and monitoring your labs on a regular basis and staying engaged in care. Also, as Bridgette has told us about. It's about, it's about being undetectable is under 200 copies per milliliter. We know that there are some tests that will detect HIV in your bloodstream lower than 200, but for the purposes of untransmittability, it's under 200. It is about sexual transmission. It is, U equals U does not apply to injection drug use or to breast or chest feeding. Doesn't mean that that doesn't reduce risk, but U equals U does not apply there. There's not enough research to prove that. And it's about HIV transmission. It's not about preventing STDs. So here is a study that was done among people living with HIV in 25 countries, including the US. And when people living with HIV who were informed about U equals U from any source, this study found that they were more than twice as likely to report viral suppression. They were also more likely to report optimal mental health when they knew about U equals U, regardless of who they heard it from. And hearing about U equals U from a healthcare provider led to better adherence and overall health. Now, these are just snapshots of what's in the study, but nonetheless, U equals U improves overall health. This is a really important study and one that I really want to highlight for testing day. This is a study out of South Africa, and the key finding is that U equals U messaging really improved HIV testing uptake among South African men. It was a simple intervention delivered in a South African mobile testing program. It showed that men were more than 89% more likely to accept an HIV test when peer workers talked about U equals U, as opposed to the standard messaging that was just about HIV testing. And so you can see the power that U equals U has to increase uptake of testing. It's really important when communicating U equals U to be clear, consistent, confident, and conscious in your communications. And I'll touch on just a couple of those here. It's important to be clear, to use language like can't pass it on, can't transmit, prevents HIV, zero risk, so that it instills confidence. These are terms we don't like to say. Negligible risk, helps prevent, effectively no risk. So it's really important to be really clear. And I want to just stop for a moment and say that CDC has recently updated their language. They used to use effectively no risk in their risk descriptions about U equals U, and now they are clear and say you cannot transmit, you will not transmit, you don't transmit. So we're really pleased that CDC has come along with this as well. And then lastly, we like to say that undetectable always equals untransmittable, but viral load does not equal value. This is really important because not everyone can achieve an undetectable viral load. First of all, treatment is a personal decision and not a public health responsibility. Some people are unable to achieve an undetectable viral load. Some people have a lot of structural barriers that make it impossible or near impossible to get to undetectable. So everyone living with HIV is valued, and all people with HIV have options for safer sex. Condoms and PrEP are options in the US. So really, it's important to remember that not everyone can get to undetectable, even though that's what we're shooting for. So with that, thank you very much. And I will turn this over to Carl Baloney.
Thanks, Maria. I really appreciate you turning it over and for all that great information. I'm just going to pull up my screen sharing for you all. All right. Sorry about that. Good afternoon, depending upon where you are. I'm Carl Baloney. I'm Vice President and Chief Advocacy Officer with AIDS United. My pronouns are he, him, his. I wanted to talk to you all first, just a little introduction about me and my work. So first of all, AIDS United is a national organization that has a singular mission of ending the HIV/AIDS epidemic in the US. We work to achieve this ambitious mission through strategic grant making, technical assistance and capacity building services, policy and advocacy based on sound public policy analysis. And while we're headquartered in DC, we're actually now a primarily virtual organization with a staff of public health and policy professionals across 18 states who work daily on building power for HIV efforts at the national, regional, and local levels, and funding initiatives for improved health outcomes for people living with HIV and prevention strategies for those most likely to be impacted by the epidemic. As of January 2021, our strategic grant making initiatives have directly funded more than 118 million local communities and have leveraged more than 184 million in additional investments for programs that include, but are not limited to, syringe access, access to care, capacity building, and HIV prevention and advocacy. From the capacity building side of our work, AIDS United has long believed it is important to provide community-based organizations with technical assistance and organizational management tools that they need to most effectively respond to the HIV epidemic where they live. AIDS United staff regularly designs and provides customized and appropriate technical assistance to communities around the country. Now, for my part, I work around policy and advocacy. Our regional and national advocacy activities are informed and driven by our Public Policy Council vision and guidance and are aligned with our programmatic work. The AIDS United Public Policy Council, which consists of more than 50 leading HIV/AIDS service organizations, is the largest, most impactful, and longest-running community-based HIV/AIDS national policy coalition in the country. For more than 36 years, the Public Policy Council has led initiatives to shape and inform federal policies that impact people living with and impacted by HIV. HIV care in the US has always included political advocacy, and AIDS service organizations have long committed to this legislative work to ensure that the US engages in sound and just policies and programs to respond to the modern HIV epidemic. The Public Policy Council and advocacy initiatives are grounded in understanding that HIV is a disease of disparities linked to race, sexual orientation, gender identity, and economic status, and that a sound response to HIV must be inclusive and reflective of the populations and geographies disproportionately impacted, ensuring that there is equitable allocation of human, material, and financial resources devoted to the most impacted communities. With all of that, it is clear that the first building block of our work starts with testing. Everyone who is sexually active must know their status. So we talked about testing as the entry point. Why? Testing builds relationships between patient and medical providers. When someone comes in to be tested, if they're met with patient, non-judgmental, culturally competent support, they're more likely to test frequently, and if positive, engage in the care system. Testing can also increase patient satisfaction, leading to greater patient understanding of their health, as well as available treatment options, which contributes to better adherence to treatment, medication plans, and providing support and reassurance to patients. Testing also provides a couple of avenues for outcomes. So we know someone goes in, you get tested. One outcome could be a negative result. Then folks are directed to prevention tools like long-acting or daily PrEP, which we've heard about from some of the other speakers, as well as information and education and condom use and other strategies to remain negative. One might also receive a positive diagnosis. Folks are then educated in what it means to be diagnosed with HIV in 2022. We've heard from the other speakers with the antiretroviral treatments available, it is not a death sentence. Providers are able to support individuals who test positive to get on treatment, attempt viral suppression, which in and of itself is a form of prevention for community known as treatment as prevention. And of course, we recognize and have heard great things from Murray about U equals U, a foundational component of the HIV care continuum. HIV testing is in a regular health screening to reduce stigma, increase awareness of status. Stigma is a major driver of this epidemic. We have to do a better job of communicating. We have to get rid of the myth that HIV is a death sentence, so there is no longer fear around getting tested and learning your status. We no longer are at risk of losing insurance coverage thanks to the ACA. We also must combat stigma through some of the local laws. There's a patchwork of laws across the country that criminalize folks with HIV status. And this is completely harmful and exacerbates HIV across the country. Also, since the beginning of the epidemic in the 1980s, drug use and HIV have been inextricably linked. The HIV/AIDS epidemic is syndemic. Substance use is a key component of spreading HIV. A powerful cofactor at every stage, including transmission, diagnosis, illness trajectories, and treatment. We must connect people who use drugs to care as well. So all of this plays into our goal of helping people live longer and healthier lives and therefore ending the epidemic. To change the trajectory in the US HIV epidemic, we require achieving ambitious but achievable goals of reaching a 95-95-95 framework for HIV. That would include 95% of persons with HIV awareness of their serostatus, 95% of those diagnosed individuals retained in care, and 95% of individuals on antiretroviral therapy being virally suppressed. To get people virally suppressed, we need to get people in care. And in order to get people in care, they need to be tested. So testing is the linchpin for ending the epidemic, which is our sole mission. With all of these tools, there are still people being left behind. There are still rising rates of new infection in certain populations. So extensive progress has been made to end the epidemic. Black and brown folks have been disproportionately affected by the HIV/AIDS virus since the epidemic's beginning, and that disparity has deepened over time, and they're being left out of the progress. Although Black Americans only represent 12% of the US population, they accounted for 43% of the new HIV diagnoses in 2018, and an estimated 42% of people living with HIV, according to the Kaiser Family Foundation. Among Black Americans, Black women, youth, and gay and bisexual men have been especially hard hit. At some point in their lifetimes, an estimated 1 in 16 Black men and 1 in 32 Black women will be diagnosed with HIV. Latinos represent approximately 16% of the US population, but account for 21% of new HIV infections and 19% of people living with HIV. Latinos represent approximately 16%, but account for 21% of the new infections. That's absurd. We must ensure that folks, Black and brown folks, have access to care, treatment, and prevention tools that are needed and are tested frequently. As the largest and fastest growing ethnic minority group in the US, addressing HIV in the Latino community takes on increased importance in efforts to address the epidemic across the country. We must all engage in our own health and take our health into our hands. And that's what the National HIV Testing Day is all about. There are other barriers to accessing care as well. Other barriers include costs surrounding PrEP. We've heard a lot about PrEP. Right now, there are structural barriers to PrEP. One has to be tested if it's the pill, one has to be tested every 3 months, have labs, follow-up. And while there are patient programs to support that, folks who are underinsured do face barriers. We're working at the national level to fund and enact the national PrEP program so that everyone who needs PrEP can use it regardless of their ability to pay or their insurance status. Other barriers also include healthcare coverage, health coverage, provider and pharmacy availability, linguistic and cultural competency issues, institutional racism, aging discrimination, so on and so forth. We really have to be able to work together to dispel these barriers and create greater access. So what can you do as members of the community to reduce this stigma? What can you do to make sure that people are tested, feel safe being tested and knowing their status? Education, talk to your friends and family members. You're learning a lot today, and you can pass along this message after National HIV Testing Day. We must dispel the myth that HIV is a death sentence, so there's no fear around diagnosis. Must remind folks you will not lose coverage if you are diagnosed with HIV. Also, everyone should get tested. If you are sexually active, get tested. It does not matter. It does not matter who you love, who you have sex with, what your gender identity is or expression. Everyone who is sexually active should get tested to dispel the stigma. Ask influential members in your community to get publicly tested on days like National HIV/AIDS Awareness Day, Testing Day, pardon me, and support public testing events. Normalize it. It's just a part of our day, and we all have to keep each other healthy. Thank you. I'm going to turn it back over to Dr. Patel.
Hi, thank you, Carl. That was lovely. I'm going to go ahead and transition over the next 5 minutes into our other advocates that we want to speak to. I'm going to go ahead and say hello to Jesus Villalobos. And Jesus, it's a great pleasure to have you here. And we want to know, in the context of, how was your HIV testing experience and kind of your PrEP linkage to care?
Hi, everyone. Thank you, Dr. Patel, for having me and that, the beautiful presentations that we've been listening to today. And honestly, the very first memory that I have that comes to my mind is my very first experience when it came to HIV. I just remember I was in rural Kansas, a very small town. And looking back now, I understand where the person was coming from. But what I took out during that first visit, I just remember the words. This weren't the exact words that were said to me, but this is what I walked away with. It was anal sex is not normal. What you're doing is not right. And you're getting tested for HIV today because it's your fault and you should be afraid, right? That kind of shaped my care for the next, what would have been the 4 years, right? I was still putting myself in vulnerable situations without realizing that there was a higher risk to the stuff that I was doing, right? So with that, I think it's very important to remember that you as providers and us as advocates is to make our spaces be a safe space, right? To be very intentional about making our spaces safe for not just our clients, but for everybody that works there, so that, because that first visit is either gonna make it or break it for your program and for the person that's there to seek services from you. One of after, I wanna say 5 years of, like I said, navigating the system, I came across with a wonderful provider that not only offered me PrEP once again, but they had a way of explaining to me, these are the resources that I have for you, and this is how we can make it better for you to stay adherent. I think what helped me a lot was that not only the misconceptions and the questions that I had were addressed, but they also had the resources on hand to help me stay adherent throughout the next years. And now it's been, 7 years since I've been on PrEP. I've tried everything from Truvada to Descovy, and I'm fortunate enough to be working with my provider to see how the injectable is gonna work for me. And Dr. Patel, what was the next question? I don't know if I've been answering correctly.
No, you covered everything, Jesus. Thank you so much.
Awesome. Yeah, no, thank you all. Thank you.
And now we'll transition to Deirdre. Deirdre, you are representing a population that sometimes is left out, especially in the PrEP conversation. So we're excited to hear from you from the angle of a cisgender woman and your experiences with HIV testing and linkage to care. Can you talk on this aspect?
Yes. And thank you so much for having all of the panelists. It's been an honor to be featured and speaking with you all and listening to these the information and these stories. My perspective comes from, I actually was diagnosed and had my HIV testing while I was pregnant. And that is when I found out my HIV status. And so I actually was living in Texas at the time of my diagnosis. And to be honest, as I think back to, just as we're having this conversation about testing, I have to be honest that my testing only came when I was pregnant. And that kind of raises a bunch of concerns, but I'm actually kind of excited that it is that way. And one piece that I would love to have, of course, is normalize, especially women that they have that option to be tested, not just by OBGYN, but any care that they are getting, that HIV testing is spoke about in any context. And during that time, back in the early 2000s, it was a lot of stigma where, oh, you only have one or two partners, or you have insurance, when we know that HIV does not discriminate whether or not you have insurance or whether or not you have the option to test for free or for a cost. So that was really my experience. And I'm really grateful that right then and there, once I tested positive, that I was ushered right into treatment right away. I am 22 years living with HIV, and my womb nugget is now 21 years old and is HIV free. And so it's been a really big piece for me to make sure that all women know about HIV, that women know about testing, that they know about PrEP, they know about PEP as well. And of course, you know, U equals U, as also an ambassador for U equals U, that folks do know that if you are undetectable, you cannot transmit HIV to your partners via sex. So I think it's really important and vital that we bring women into the conversation. But even more importantly, I think we need to really up the game when it comes to PrEP and PEP, when it comes to cisgender women, and really to all women that have access to PrEP and PEP.
Thank you so much, Deirdre. And now we'll open it for question and answers. I did not see anything in the Q&A section, nor did I see anything in the chat. And I'd like to remind all our panelists, if you could turn on your videos and unmute so we can answer questions. While we're waiting for questions to roll in the next 3 or 4 minutes, my first question is posed to Murray and Bridgette. And I just want to ask to you, what do we do when someone isn't undetectable, and what is the messaging around that? Murray, you can start.
I will start. Yeah, thanks for that question. Really important question, and I appreciate the follow-up on what I talked about. You know, there are options for having safe sex when you're detectable. You can use condoms. Your partner can be on PrEP, and we know PrEP is 99% effective at preventing transmission. So those are options. And I think it's just really important not to shame the individual when they cannot get to an undetectable viral load as well. Bridgette.
You know, one of the things that I would point out is that sometimes people that have been living with HIV for a long time think that they're out of options because they've been doing the same thing over and over again. And that's the point where it's important to have a conversation with your clinician or your provider, because they do have a number of new medications that are specially made for persons who have a lot of resistance to their current medication regimens. So that's an option to explore. And the other thing is, and I can't reiterate it enough, is to remember that you are not your status, right? Like, you're not HIV. HIV is something that you've acquired and that you are living with. And so it's important not to let that diminish who you are in your eyes, whether you're undetectable, detectable, in care or not in care. We stress being in care, but it's important that people who, for whatever reason, have chosen not to get into care understand that they still matter and they still have value. And when you're ready, make your way and we'll get you taken care of.
Thank you so much for that insight. I have a question for Brian while we're still waiting for questions to roll in. Brian, just through everything going on that you've reported, what are your advocacy pearls that you have as advice for the audience?
For me, when I advocate for people living with HIV, I think the biggest thing we have to really recognize, and it's been mentioned so many times in this call, is that these people are human. And a lot of times, a lot of people living with HIV, they have experienced trauma throughout their life before they get this HIV diagnosis, that we have to take that into account too when we're trying to, move them forward into care. I think one thing that Murray said in his presentation that really stuck with me is that getting people into treatment is a personal decision and not a public health responsibility. You have to realize that when people go through certain traumatic experiences, sometimes that can lead to a lot of mistrust, especially in our medical system and society in general. So we have to really, truly delve deeper into those barriers that people are going through intrinsically so that we can help them move forward and advocate on their behalf.
Thank you, Brian. And while I have you on center stage, I have a follow-up question. In terms of having sensitive conversations with persons in front of you around testing, do you have any advice when someone does disclose they're monogamous or they have one partner, but they still may be at risk in many ways? How do you open up that conversation? And this is the advice for the testers in the room, the other HIV prevention workforce staff, including providers, trainers for HIV testing.
Yeah, that's a great discussion. I always have conversations with my patients about their monogamous relationships. Like, I always talk to them about, have they had those discussions around sexual health in their relationship? Because a lot of people get together and people have this misconception in their head that people living with HIV or with STDs look a certain way. So a lot of times they don't have that conversation about, well, when was your last test? Anything like that pertaining to sexual health. Also, a lot of times I think people have to have this this realization that everybody's definition of monogamy is different. So people may view a relationship, I may view a relationship one way in terms of being with one person, but another person may view a monogamous relationship a little bit differently. So you have to realize that I would always tell people who are in these monogamous relationships that they have to always be their biggest advocate, no matter what. You cannot instill all of your trust into somebody and expect them to have your back 24/7, because at the end of the day, you are your biggest advocate. So people that are in monogamous relationships, I always inform them that, HIV doesn't care what your relationship status is. It doesn't matter what your social economic status is. It does not matter what color you are. It does not matter your sexual orientation. At the end of the day, HIV is human immunodeficiency, human immunodeficiency virus, and it can happen to anybody, no matter what your status in life is. So I always advocate for people, no matter if they're in a monogamous relationship or not, to at least get one test every single year to make sure they know their status.
Thank you for that wonderful advice. And I'm going to hand it over to Diane Lavinia to close out our session today.
Great, thank you. That'll conclude today's program. Thanks to the sponsorship of Roche Diagnostics. Thank you, Dr. Patel, for moderating and for your amazing contributions. Special thanks to Carl Baloney, Marie Penner, and Bridgette Picou for your insight. To our patient advocates, Michael, Brian, Jesus, and Deirdre, thank you so much for sharing your incredible stories and elevating the importance of HIV testing. I also want to acknowledge our audience. Thank you for attending today. If you're interested in listening again or want to pass this webinar on to someone else, which I hope you will all do, the recorded session for today's webcast will be available on our website in the next 2 to 3 business days. And that's at idsafoundation.org/your-health. Again, thank you all for participating, for attending, and have a great week.